Good morning, good afternoon, or good evening, depending on where in the world you are joining us from. A warm welcome to this FIP digital event, which is entitled Pharmacists Against AMR, Antimicrobial Resistance, Specialization in Communicable Diseases for a Stronger Impact. It is part of the FIP World AMR Awareness Week digital event series. Thank you for being here or there on the other side on the screen. My name is Carlos Fernandez Moriano. I'm the Deputy Director of Pharmacy Services and Professional Development within the General Pharmaceutical Council of Spain. I'm glad to co-moderate this interesting session together with my colleague, Dr. Dalal Hamoudi Halad, Common Year Coordination within the Health Assessment and Accreditation Office, Health Sector of Qatar University. She is also an FIP AMR Commission member. Next slide, please. Well, before we begin, just a few housekeeping notes. This webinar is being recorded and live streamed via YouTube. The recording will be therefore available on our website, www.events.fip.org. You may feel free to pose your question at the box provided. We will have a final part of question and answer section and debate. And you are welcome to provide your feedback at the end to webinars@fip.org. And we encourage you finally to become a member of the FIP at the fip.org website, where you can register yourself. Please also note that you will have available a translation feature or tool on Zoom app, for which you have to follow several steps. Firstly, you have to turn on captions. Secondly, enable the translation toggle. And step number 3, choose your preferred language under My Caption Language. Afterwards, you will be able to follow along with the live translated caption. As I said in the beginning, this digital event is part of the FIP AAW Digital Event Series 2025. We will introduce our panelists soon. But I would like to mention that from today till the 24th of November, you will also have available other 3 digital events. You have the titles on the screen. So we encourage you to follow all of them, because for sure they will be pretty much interesting. And finally, I would like to encourage you to register this WAAW, which is an institution. It is encouraged also by the World Health Organization, and you can scan this QR code on the screen to access all the information. At this point, I would like to hand it over to my colleague, the co-moderator, Dr. Dalal. Please, Dalal.
Thank you, Carlos. Hello, everyone. Good day and good evening to whichever parts you are in the world, and thank you for joining us for this event among the series of the World Antimicrobial Awareness Week organized by FIP. I'd like to thank FIP also for taking the initiative and organizing these events and for inviting me to co-moderation. It will be a nice encounter with lots of expertise colleagues from different parts of the world. So the learning objectives of the current webinar are to explore various pharmacy specialties and understand the effect and the utility of pharmacy specialization in communicable diseases. Also, for pharmacists as leaders in antimicrobial resistance, this event aims to understand how pharmacists will play a crucial role in antimicrobial stewardship and the overall proper use of antimicrobial agents safely and effectively. Also, during our webinar, you will be able to discover how to develop and establish the concept of pharmacy specialization in communicable diseases through the different examples that will be shared by our panelists. And we will be focusing on low and middle income countries. Next slide, please. So in a nutshell, what are we going to discuss today? The program, now we are introducing our panelists and the general program. And then we will move over to infectious disease physicians and pharmacists, synergies to improve antimicrobial utilization. This will be our first presentation. The second presentation will be ID pharmacists and enhancing patient care and outcomes. Next, we will move to 2 exemplars from low and middle income countries. One will be from India, the emerging role of specialist pharmacists in low and middle income countries, innovations from India. And the second one will be from Ghana, so specialization in pharmacy practice, Ghana College of Pharmacists. This being said and described, we will then have a chance for some Q&A, interactive session, and then we will be able to close this webinar with our final remarks and recommendations. Next slide, please. We would always like to link the online events to the FIP development goals. So the primary development goals, of course, are FIP development goal 17 on antimicrobial stewardship, in addition to development goal 16 on communicable diseases and 19 on patient safety. Yet the current event also links to other secondary development goals. For example, development goal 4, advanced and specialist development, development goal 6, because of the ability of antimicrobial stewardship pharmacists to develop leadership competencies, in addition to others, for example, advancing integrated services within pharmacy, working with others on antimicrobial stewardship, the impact and outcomes of pharmacy activity and specialization on AMR, policy development for AMR, expertise in medicines, specifically antimicrobial agents. The event also links to people. So it is people-centered care in FIP development goal 15, and also the access to medicines, devices, and services in the FIP development goal 18. So these are the different development goals that primarily and secondarily link to our event today. Next slide, please. It is a pleasure to share with you the FIP Copenhagen Declaration on Antimicrobial Resistance. Last August and September in Copenhagen, FIP held the 83rd World Congress of Pharmacy and Pharmaceutical Sciences, and during this event, 82 member organizations did share a common declaration on AMR, by which they all have recommended to raise the awareness about AMR in different regions of the world, across different categories of healthcare, to support also global efforts in order to build partnerships for combating AMR across the world, and also to support different strategies, for example, vaccination, the rational use of antibiotics, public health education and empowerment, strengthening global medicine supply chain in order to provide enough antibiotics, and also work on innovative technologies for antibiotic development, and also to have enough evidence on AMR interventions and AMR impact. We invite you to scan this barcode in order to read this declaration, and also to visit the legacy video, which was photoshooted during the FIP Congress, in order to get a better idea about this declaration statement. Next slide, please. I'd also like to invite you to see an update in which the FIP Antimicrobial Resistance Commission is issuing a report on antimicrobial stewardship programs in hospital setting. This report has been drafted by members of the AMR Commission in collaboration with many pharmacists who work in AMR and AMS, and it is going to describe the different policies of AMR and AMS in the 6 WHO world regions. It is also going to describe the preliminary findings of a survey launched by FIP in 2024 in order to highlight the important findings about pharmacists and antimicrobial stewardship programs. So I will hand again the presentation to my colleague Carlos, so that he will start introducing the speakers. Thank you.
Thank you, Dalal. So let's move to the point of the event today. And it's my pleasure to introduce you our first speaker, Dr. Gautam Kalyatanda, who is an associate from the USA, who is an associate professor of medicine at the University of Florida within the Department of Medicine and the Division of Infectious Disease and Global Medicine. His presentation today is entitled Infectious Disease Physicians and Pharmacists, Synergies to Improve Antimicrobial Utilization. Next slide, please. Dr. Gautam Kalyatanda is, as I said, an associate professor of medicine and director of the Infectious Disease Fellowship. She's also working as an associate director of global health and local health equity track within the College of Medicine, from working at the University of Florida. So now, Dr. Gautam, the floor is yours.
Thanks so much, Carlos, for that introduction. So I also run the OPAT service at the University of Florida, and I will bring about some examples as to how integral the ID pharmacist is in our entire setup within our division and department. So we all know about the global threat of antimicrobial resistance, and I'm sure we will be talking about this quite a bit. I don't belabor you with all of this, but it is estimated that about 10 million deaths caused by antimicrobial resistant pathogens by 2050. And as you can see from this map from the Lancet, looking at CREs, it disproportionately impacts countries in the low middle income category. I think one of the places that we're really not focused in terms of our antimicrobial stewardship efforts have been primary care, whether it's developing or in developing countries. Now, talking about Sustainable Development Goals of the UN, which I'll come to later in my slides, there is poverty reduction, and we really see from this World Bank report that if we want to achieve those goals, then it becomes really hard without taking care of these resistant pathogens, because it's estimated that the cost of these pathogens in terms of healthcare is going to be about 120 trillion by about 2050. Next slide, please. Again, I know Dalal went through a lot of these development goals from the FIP, but it also includes, finding transdisciplinary collaboration to advance education, research, and development, and then inter and intraprofessional collaborations in multidisciplinary healthcare delivered through cohesive and different teams. So a lot of what I talk has already been kind of one of the goals of the FIP. Next slide, please. So when we look at these synergies, and I kind of wanted to go through what does each one of them contribute by themselves. And so I think I'll go with ID physicians first. And I think in this day and age of molecular diagnostics, where you can get any panel you want and gives you results in little over an hour or so, I think the role of the infectious disease physician has never been more important. The need to differentiate between colonization and infection has never been more urgent. They also provide a lot of clinical leadership in AMS, at least at our university. We kind of work together to find, and then we kind of provide the teams a lot of those inputs. There's clinical assessment and risk stratification, right? So we have a lot of patients with a lot of comorbidities today, having a lot of conditions. And then I think the physician kind of helps stratify risk and assessment, and through that also kind of manage these complex patients taking multiple medications. And then there's also guideline and teaching, guideline development and teaching, which we kind of contribute in this realm of antimicrobial stewardship. Next slide, please. So what about the pharmacists? And again, at where we are at the University of Florida Shands Hospital, we do a lot of therapeutic drug monitoring, and the lab run by Dr. Charles Pelequin, who you all know does a lot of this. And so a lot of these results, we reach out to our pharmacy colleagues who help with dosing in renal and hepatic dysfunction. So again, going back to kind of these patients with multiple comorbidities, never been more important to have the pharmacy input. Drug reactions, a lot of these patients, again, polypharmacy, many medications, very important to kind of talk to our pharmacy colleagues to find out what drugs to dose, and the dosages as well. So a lot of patients I see are non-tuberculous mycobacteria, which means I had to add rifampin, and then making those dose adjustments to these other medications becomes ever so critical. They really help with even informing ID physicians and the entire team about when to switch from IV to PO medications. And I think without them, we'd go on for weeks without changing them from IV to oral medications. There's been a lot of data about discharge stewardship. So even having an ID pharmacist take a look at the discharge summary, kind of go through those medications with the patients at this transition point is very helpful, especially with patient outcomes. And then community level education, I think, again, is very important. So really, the pharmacists are at the forefront of the community. They are the first point of contact most of the time, especially in low and middle income countries. So working a lot in terms of preventing infections, diagnosing infections, and also finding and surveillance of emerging infections. I think they play a huge role in all of these things. Next slide, please. So I really like this slide, which if you look at what we have, a multidisciplinary kind of model of taking care of patients, there's skill-based versus task-based, and skill-based is really what we should be doing. So you have physicians, nurses, dentists, all of them could be prescribing antibiotics or dispensing them. Then you have the general public. And in some places of the world, there's easy access to antibiotics, both as an inpatient, outpatient. And then there's all these allied healthcare workers who can also prescribe. And I like this primarily because the pharmacist is right in the center, coordinating this extremely difficult patient treatment regimen with all these different people, and they're really at the center of this entire process. So again, why it matters, there's complementary expertise, and there's shared stewardship goals with ID physicians. So at UF, most of the stewardship is kind of run by the ID pharmacists. So they kind of look through all these antibiotics that are dispensed. And then if there is a need for an ID consult, they would suggest to the team to do that. But a lot of that work is primarily done by the ID pharmacists. And again, it's essential for safe, effective antimicrobial use. So really, teamwork, if you really want to see how that works, I think this is a great model. Next slide, please. And this is our great team at UF. And we also have some of these ID pharmacists from the VA. So they're all associated. And I kind of just want to take you through some of the things we do. So all our rounds we have ID pharmacy input, and that's really important for us for that third bullet point there, which is education. I think, when as a program director, when I interview applicants for the ID fellowship, I really tell them that one of the biggest strengths we have is that we have ID pharmacy fellows rotate with us, ID pharmacists rotate with us, and the amount they can teach us and our fellows is invaluable. So I think taking care of our patients, they're invaluable. Educating us, they're invaluable. When patients are discharged home on antibiotics, which is OPAT, we have ID pharmacists on our team because, as you all know, the rates of readmission and side effects when patients go home on IV antibiotics is extremely high. And I think it's been shown over the world that having a multidisciplinary team with an ID physician and an ID pharmacist really brings those rates down, both readmission and side effects. We do joint stewardship interventions together. We kind of work as a team. There's also infection control that we work as a team. And then there's a lot of real-time feedback. There's protocol development. And then most of the ID pharmacists are actually working with the microbiologists, with the infection control. So a lot of times they're the ones who tell us what's happening with the patient. And especially in this day and age, and especially intensive care or critical care medicine, when you have 4 or 5 different teams taking care of a patient. So there's the primary team, there's the ICU team, and all the other teams. people we reach out to is the pharmacist who's taking care of the patient, because they usually are well aware of all the what's happening with the patient. So I think it's really a multidisciplinary approach towards patients that we have. Next slide, please. Again, so I think this is really well. I have some co-panelists who will talk about this in a lot more detail, but I think this is really, if we really want to kind of help with antimicrobial stewardship, it has to work out at the primary care level in rural parts of the developing world, which again is one of the most important settings. So I think I'm running out of time, so if I can go through the slides. Do I have enough time?
Yes, Katon, please continue.
Okay, all right. So I kind of want to go through a few of these. I think 3 more clicks, because you'll have a few pop-ups come up. Yeah. So again, I think one of my co-panelists here has written this great article about community pharmacists and antimicrobial resistance stewards, and I'm sure she will talk a lot more about what is happening in India. There was a study we were involved in where we looked at patients who went from villages to a tertiary care center, and we were shocked that more than 40% of them had CREs when they were really treatment naive. So I think that's really the frontier we need to conquer, right? At the rural parts, primary care, to kind of improve that. And who better to do that than trained clinical pharmacists? Next slide, please. All right. So I think so what does synergy bring? Better antibiotic selection, shorter durations of therapy, early de-escalation, shorter hospital stays, safer discharges, and reduced broad spectrum use. Next slide, please. And again, going through the SDGs, I think we really have to focus on good health. So you can't do that without controlling AMR. There's poverty and economic growth, again, which cannot be controlled without controlling AMR. There's partnerships, which we're talking about, and this is really the most important one, isn't it? SDG 17. And so across ministries, global partners, sectors, but also across different multidisciplines within the healthcare team. And I think that really speaks to the pharmacists and the physicians taking care of these patients. Next slide, please. Okay, and there are obviously challenges. There's workforce shortages, as all of you know. There's lack of trained clinical pharmacists. There's culture of healthcare, which means that those interdisciplinary team dynamics are at risk, because the culture is that as some physicians wouldn't want to be told what to do or provided that input. And there's cultural expectations around antibiotics as well. So the longer, the better. Next slide. Okay. I think we'll touch upon a lot of these things. There's joint training of ID physicians and pharmacists, which I think is now moving to different countries across the world. I think that is really important. There's government and NGO partnerships, because you build policy, and that helps kind of helps with buy-in as well. Next slide. So this was an interesting article I kind of looked at in the era of planetary health, where we're looking at health and really from a more holistic viewpoint, rather than a purely biomedical standpoint. It's never more important to have all these people have a stake in taking care of our patients. And I think this is really going to be the next level where all of us talk. You can't get rid of AMR without having the veterinary folks, dentistry, nursing, pharmacy. And very important, because now the UK by 2026 will have pharmacists being able to prescribe as well. So I think this is a great change, because we really are addressing the shortages for healthcare personnel, but also kind of taking care of patients with a multidisciplinary viewpoint. Next slide. Again, in conclusions, I think pharmacists are really the essential AMR leaders, whether it's in the developed nations or the developing world. And the synergy improves outcomes in all settings, like I said, whether it's in the US, in a developed setting, or in the developed world. And collaboration leads to improved antimicrobial utilization. And we've seen that across different geographies, different healthcare systems, and across economies and developed versus developing countries as well. Next slide. All right.
Thank you, Dr. Gautam. It was a really insightful contribution. So now, and many thanks, really, because the perspective was truly valuable. So now it's time to move on to the following presentation. We are honored to have with us Dr. Noor Shamash, from Lebanon. She's an infectious disease clinical pharmacist and also works as an independent antimicrobial stewardship consultant. Over to you, Noor.
Thank you, Carlos, and thank you to the organizers for inviting me to share my thoughts on our work as infectious disease pharmacists, and really also enjoyed the Gautam's presentation, which nicely sets up for mine. So I'll just preface this by mentioning that I'm an infectious disease pharmacist, as mentioned, and I currently work, well, first, it took me a while to get to where I'm at now. So I was first a critical care clinical pharmacist with ID focus, and then I worked in clinical trial research in infectious diseases, and then I was an ID clinical pharmacist, and I led the antimicrobial stewardship team for over 8 years in a hospital in Saudi Arabia, and then I did my global health policy masters and became a technical and policy advisor. And very importantly, all throughout, I was a strong patient advocate and a community organizer for whatever I thought at the time needed to be organized. And the reason for me to share this is that our path as stewardship or infectious disease pharmacist isn't typical outside of certain countries like the US or certain countries that already have established clinical pharmacy and specializations. Is not exactly a direct path, and it takes a lot of different approaches and could take many different forms, and this is what I hope to share with you today. Next slide, please. So who counts really as an ID pharmacist? Because in the literature, you're going to see ID specialized pharmacists, or you're going to see pharmacists with ID focus, or you're going to see different terminologies used. And this is what I've kind of tried to summarize here. So pharmacists working in ID settings, in fact, infectious disease settings, pharmacists with infectious disease experience or interest, so potentially without specific training, infectious disease or antimicrobial stewardship pharmacists that have specific training, such as an ID or AMS certificate, a master's in epidemiology or communicable diseases, or potentially a pharmacy residency. And we know that this isn't accessible even in countries that have, such as, well, any country that has already training for pharmacy residencies and specializations, they also have a hard time with the number of residencies that are available compared to the number of pharmacy specialists that are needed. Next slide, please. So in general, I think it could be and should be expected that anyone with a pharmacy background should be a candidate to become trained, to become an ID pharmacist. Of course, where you start from is different, and the type of application of your practice could be different. But given the fact that the literature suggests that we should have around one pharmacist for each 100 beds versus one pharmacist to each 300 beds, the recommendations differ in different articles that are focused in infectious disease. That tells us that we can't wait to set up pharmacy residencies to have a really impactful antimicrobial stewardship program and infectious disease specialists. And I also will say one thing, even though an ID pharmacist tends to usually do the stewardship work and vice versa, sometimes and ideally you would have multiple people doing all of that work, because especially if it's a larger facility, because you might end up having a lot of, let's say, clinic-based ID work, such as in HIV clinics or hepatitis clinics, or you could have more stewardship-focused activities. Next slide, please. So I'll just run through what, I mean, Gautam already touched on this, but what are some of the competencies of an ID pharmacist? So it could be, I always mention, if you noticed, experience or training in clinical ID and stewardship, PKPD, so pharmacokinetics, pharmacodynamic optimization, and antimicrobial optimization in general. Next. Data interpretation. So how would you evaluate your antimicrobial consumption at your facility, whether it's a inpatient or outpatient or like a primary care setting? As Gautam mentioned, we don't often think about stewardship implemented in primary care, although that's very important. Thinking about quality improvement and research. So at one point when I was implementing stewardship initiatives, I realized that I really don't know how to manage a project from a quality improvement perspective. So I did specific training in that. So I'm Lean Six Sigma Black Belt certified. That took a lot of time to change my brain from clinical to more quality improvement approach. Guideline development and evidence-based approach to giving recommendations. But also I'll mention being smart of how you use your time so that you're not repeating things that are already available. So if there's a national guideline available, there isn't a need for every single facility to develop tailor-made guidelines. And I know this tends to be the recommendation in many documents, but we can talk about that later. And very importantly, education and mentorship, being able to share your information with someone else. Next, please. Communication and behavior change skills. So at the beginning of my practice, it was very logical for me to go into rounds and suggest a change from antibiotic A to antibiotic B, or to stop an antibiotic. And then you realize that you have to really think from a multidisciplinary approach, that at the end of the day, no one walks into the hospital thinking, I'm going to misuse medications today. So how can you really get that person to think with you and change practice together, rather than forcing people to change practice? Leadership and coordination, of course, and policy and systems thinking, which we tend to forget about, which is, if you implement a policy in your hospital, how likely are you to harm people versus how many people are you going to help? And making sure that even if it's one person that you harm, how can you mitigate that, and making sure that you have safe policies implemented in practice settings. Next slide, please. So what do the pharmacists working in infectious diseases of any sort, what can they do? So they can, of course, improve pharmacy practice in general. They can focus on inpatient or outpatient or community practice, stewardship and ID prescribing. They can do research and surveillance. It seems my internet is unstable. Please let me know if this continues. Next, please. Project leadership and management, as we said, leveraging digital platforms and making work as simple. And I use the word lazy quite a lot when I'm working with my residents and interns, to remind us that we really shouldn't be, we should really be trying to make our work as smooth as possible. Education and capacity building, and I will highlight also the type of work that could be done outside the hospital, such as in humanitarian projects, in healthcare and policy and regulation, such as people working at FIP or the WHO or other organizations like Doctors Without Borders or local organizations, therefore potentially also providing emergency support and response. And last but not least, advocacy for your patients and for the pharmacy profession and healthcare in general. So the question is, how do you get to the point where you can provide these types of services? So we mentioned already the variation. So it could be self-directed learning or on-the-job exposure. It could be practice-based experience. So you could have participated previously in another AMS program or antimicrobial stewardship program or audits or point prevalence surveys. You could have done short courses with different societies. And this is not a promotion for one over the other. This is just some of the quick ones that I mentioned. Certificates in stewardship or ID or epidemiology or quality improvement. Board certification as well as one option, but board certification on its own is and it is really good. I'm talking about board certification in infectious disease pharmacy. It's on its own is it's really good, but also requires some support. Next, please. Also, you could do a master in science or master in public health with an ID or AMR focus, or last but not least, residency and fellowships in stewardship and ID. So if you've noticed, I put that as the last option, just knowing that many people don't have access to this. And even if you did live in a country that provides this type of training, you might not get it yourself because of the limited positions. Next, please. And mentorship. And there's a lot of focus now, and hopefully more focus soon, on the importance of mentorship and how you, with your training, you need to always find a way to be a mentor and a mentee at the same time. Next, please. And I think Gautam already mentioned this, but I'll highlight some other, like a different way of thinking about it, in the sense that why are pharmacists uniquely at an advantage to deliver stewardship and ID services? Why is it that we end up running a lot of the services in facilities that allow us to do so? And hopefully all should be allowing this and supporting this. It's because we tend to see the healthcare system from start to end of a patient's admission through someone receiving a prescription for an antibiotic. We also tend to see prescribing patterns from inside the pharmacy, because we tend to potentially have to deal with stock of medications. I mean, we can detect behaviors and patterns, because since we're not the ones prescribing, usually we can observe, and observation potentially can be very powerful. We can identify gaps in documentation, because we have to understand what's happening, and this is how we do our interventions. So we can identify opportunities, and such as IV2PO and early discharge, and many other opportunities. Next, please. So we really have a bird's eye view that allows us to design effective interventions. Next, please. The other part is that we have the potential to change behavior, because compared to other professions, we are forced to, because we're not the ones prescribing, we're forced to find suitable ways to communicate with others. And it's not just us. So nurses do this, physicians do this, but specifically pharmacists also, we end up having to do this because we have to communicate with multiple professionals, and hopefully provide non-judgmental feedback, even though sometimes you might be internally judgmental, but you're forced to find ways to communicate it in a good way. And coaching junior and senior physicians, and engaging nurses in stewardship. So for example, I know that we don't tend to think of nurses as stewardship leaders, but in my previous facility, we set up a nursing stewardship program, and we hired a nurse antimicrobial stewardship nurse who was an infection prevention control nurse and a pediatric ICU nurse previously. And this decision was really one of the best that I've made, because implementing stewardship without nursing is really very limited, I would say. And last but not least, patient and family counseling. The last part of this is, just like I said, the continuity across units and working with multiple departments and having to communicate. So it really makes us understand the patient journey from A to Z, and that helps us deliver better stewardship and ID service and care. Next, please. Yeah, and so there are a lot of studies, this is just one, that look at the participation of pharmacists and clinical pharmacists in infectious disease without training in antimicrobial stewardship. So as a clinical pharmacist, even if you have an infectious disease trained clinical pharmacist, at the end, they're going to have to work with other pharmacists in order to be able to be impactful. They can't on their own review every single antibiotic or antimicrobial in the hospital. Next, please. And there are a lot of efforts to try to improve how we train pharmacists. And so this is an example from Saudi Arabia, where they evaluated pharmacy curriculums to understand how do the professors, or how do the curriculums in fact prepare pharmacists, even without specialist training, to be good stewards of antimicrobials and infectious disease pharmacists. And in Saudi Arabia specifically, the results suggest that there is a 60% of respondents are happy, but I think that there's always room to grow. 60% is great, but there's always room to grow. And the WHO has published previously in 2024 this antimicrobial resistance curriculum assessment for medical education, but they are also in the process of developing one for pharmacy, which means you can take this curriculum assessment and evaluate your own curriculums at pharmacy schools to identify if you could improve how you could train junior, upcoming pharmacists and physicians in stewardship and pharmacy. So this helps reduce the need for or bridge the gap in pharmacy specialist training. Next, please. And I'm sharing here an evaluation that we did in the Eastern Mediterranean Regional Office with the WHO, and it focused on a mixed method study that evaluated barriers and facilitators, and most importantly, opportunities for scaling up hospital stewardship and AMS. And we interviewed many organizations, including FIP and some of the people on this call. I'm very grateful for that. And we identified that there are several things that specifically for the EMRO region are needed, but of course this could be applicable to other regions. So this includes stewardship program structure, and I highlighted points 2 and 3, which are training and education and mentorship and centers of excellence, because we know that training and education takes time, so mentorship is really key. And of course, I'll mention accreditation and operational tools such as calculators or form templates that you could use for stewardship. 6 is networking, which was really, really important as well. And last but not least, supporting a regional research effort so that you can improve implementation. Next, please. And this is what we came up with, which is a framework to try to ensure that pre-service education includes stewardship and AMR training, and then in-service education focuses on the same topics, but also special trainings on stewardship for those who are already graduated and already working in the field, coupled with mentorship. And this is the perceived potential or suggested approach for scaling up stewardship, at least for EMRO and potentially for other regions. Next, please. I'll just mention that this document includes a mapping of regional and international organizations. So if any of you on this call are interested, they could look at the specific supplement 5 of this article. And we tried our best to map as many organizations as we could. And we are surely skipped some, and I'll be happy to hear from you about others. There are 19 organizations mapped in the sense that each organization, what can they provide, what can they support you with, and who to reach out for, depending on what part of your stewardship journey you're in. Next, please. So the take-home message from my perception of what I hope that you can all remember today is that the concept of ID pharmacy should go beyond just someone who is a trained specialist. And if we really wanted to implement stewardship and really achieve national action plans on AMR and really the global action plan goals in general. And really we need to be creative and find out how we can advocate for our training in different ways. Thank you.
Thank you so much, Noor, for this informative presentation and the all-inclusive approach towards antimicrobial stewardship that extends beyond pharmacy to involve all other stakeholders as well as people. That was very interesting to learn from you, and also thanks for sharing your experience. We come now to our third speaker, Mrs. Manjiri Garat. I have worked with Mrs. Manjiri for a long time in the Antimicrobial Resistance Commission of HIP, and I am looking forward to what she is going to tell us today about India, her country. Ms. Manjiri is the principal of Kandohani Pharmacy Polytechnic in her country, India. She is also the project lead and director and the infectious disease pharmacist in the Indian Pharmaceutical Association. She is also the vice president of the CIRPharm Forum and a member in FIP India Envoy. Mrs. Manjiri, we are looking forward to listen to you regarding the emerging role of specialist pharmacists in low and middle income countries, innovations from India. Welcome, Manjiri. The ground is yours.
Thank you so much. Thank you, Dr. Dalal. Pleasure to be here. And thank you to FIP for organizing this session and having me to speak about the project that we have done recently in India. Also very happy to have co-panelists who are my colleagues like Dr. Noor and Dr. Gautam, and of course, Dr. Dalal here. So coming to India, as you know, India is a very big country. And before I go to the project that we have run in India, I would like to tell you about the scenario of pharmacy practice. We are a country where we have more than 1 million pharmacists. Yes, so you heard it right. So we have almost 900,000 or more community pharmacists and maybe 100,000 as hospital or clinical pharmacists. But the pharmacists in India are more just as dispenser or the traders, and they have not yet got transformed to the healthcare professionals. So we are on a journey, or we are on a mission at Indian Pharmaceutical Association with the mentorship of FIP to do so. But today, no. So pharmacists are traders and dispensers of medicine. So far, there is no specialization introduced into pharmacy practice. Our Bachelor of Pharmacy, the pre-service education, mainly focuses on industrial pharmacy. And we got PharmD program, Doctor of Pharmacy program introduced way back in 2008, because of which the patient care services or the clinical services came into focus. Clinical pharmacists, though now we have many PharmD program colleges, but then clinical pharmacists are not yet made mandatory post in all the hospitals across the India. So this is right now the scenario of our community and hospital pharmacy practice in India. Next slide, please. Next slide. So as very rightly emphasized by Dr. Noor, that the ID pharmacists are must and they should be part of the healthcare team and they should be important. They're important components for the antimicrobial stewardship programs in the hospitals. But the concept of ID pharmacy is recognized globally, as Dr. Gautam also told us in a very detailed way. But ID pharmacists play a very vital role in antimicrobial stewardship as well as the rational use of medicines and antimicrobials. But in India, the concept of ID physicians, or specialization among physicians, had just evolved recently. So ID physicians, the concept has evolved very recently. So you can imagine that the concept of ID pharmacist, or for that matter, any specialization in pharmacy or among pharmacists, has not yet developed in India. Next slide. And so Indian Pharmaceutical Association, which is the oldest pharmacy professionals association in India, which was established in 1939, AMR has been one of the priority areas for IPA. And we have been working in the area of AMR, improving the use of antibiotics, responsible use of antibiotics since last 2 decades. So considering the situation of AMR, considering the situation of lack of specialization among the pharmacists in India, we took up the project, Infectious Disease Pharmacist Project, with the support of Pfizer. Can we go to the next slide? And when we were thinking of organizing this project, the ID Pharmacist Fellowship Project, we had decided to focus on some of the development goals from the FIP, mainly the goal DG17, antimicrobial stewardship, DG16, communicable diseases, and DG8, working with others. As rightly said by Dr. Gautam, the interprofessional learning is very important, which is lacking in India at the moment. And interprofessional working is also not yet very common. So we wanted to bring all these aspects together in our project, which is ID Pharmacist Fellowship Project. Next slide, please. And so in 2024, with the help of with the support of the educational grant from Pfizer, we developed this project, as I said, ID Pharmacist Fellowship Project, which has been the first of its kind of fellowship in India for the pharmacists. And it was decided after discussion with the Pfizer team and the team of IPA that we will offer 10 fellowships and it will be for 1 year duration. Next one. Then the first step was always the project committee formulation. And I'm very glad that in our project committee, we had a mix of ID physicians, clinical and community pharmacists, academicians, and public health experts. Next slide. So all these names that you see, I mean, I'm sorry for a very small font of this, but then we had ID physicians, we had public health experts, we had clinical pharmacists specialized in ID and working in area of ID in India, as well as we had board certified clinical pharmacists specialized in ID specialization from US, like Dr. Gress. And so this was the team we formulated to take forward this project in year 2024. Next. And so the aim of the fellowship was always for clinical excellence, to cultivate the exceptional clinical pharmacist with specialized knowledge in ID, interdisciplinary collaboration, collaborating with the physicians, ID physicians, microbiologists. Developing participation of these fellows was planned in antimicrobial stewardship, and to prepare the fellows for roles in education and training, equipping them to educate the future generation of the pharmacist and healthcare providers. Next slide, please. So this was the objectives of our fellowship program. So the project development phase was for a couple of months, and the first task was to select the hospitals. So we approached the tertiary care hospitals where there were already ID physicians and the clinical pharmacists. So we approached 10 hospitals from southern part of India and north and west together. And the concept note was developed because, see, this was the very first time this was implemented. So the concept of ID and could be the what would be the role of face to 10 hospital and he signed an MOU with the hospital for a fellowship. Next slide, please. So this was the, next slide, please. Can I have a next slide? So after doing the, hello? Can I have a next slide, please? Yeah. So these are the names of the hospitals, mainly from southern part of India, one from northern part of India, and one from the western part of India. So these were the hospitals. So these were the hospital sites for our fellows. Next slide. So then we sent a call for the fellowship in January 2024, and it was clearly stating that the eligibility criteria would be Doctor of Pharmacy or Master of Pharmacy with pharmacy practice or clinical pharmacy. And so then we, so after floating of the fellowship program, after we were confident that the hospitals are ready to participate, to collaborate with us, we sent out this call in January 2024. Next slide, please. Next slide. A slide before, please. So parallelly, when we sent out the call for the fellowship, our project committee was working to develop the fellowship curriculum, which mainly included the clinical rotations, didactic education, and the research opportunities. And so we took into consideration the curriculum developed by I hope you can hear me. So we developed the curriculum based on the curriculum from the BPS as well as the Society of Infectious Diseases and many other resources. Next slide, please. Yes. So this is the framework and the structure of the curriculum. The program orientation, clinical microbiology and infection control. So we made the curriculum as well as the framework very clear, allotting number of weeks for each part or each part of the structure of this framework. Next slide, please. And the project materials which we developed during for this fellowship program was the curriculum, also the different formats for the fellows, rules of procedure for the fellowship, of course, the MOUs with the hospitals. Then we developed a web portal dedicated completely to this project with the support of Avenida, and a repository of the study materials for which the entire team supported us to gather the resources. And then monthly work done program reporting formats were developed, collection of the reports from the fellows who attended the external conferences, workshops, AMS workshops, etc. was done. And finally, the certificates were given. Next slide, please. The training model that was developed for this fellowship was basically hybrid learning, the online sessions by the ID experts and the on-site clinical training with the under the ID physicians, clinical pharmacists, as well as the microbiologists. Mentoring was mainly done by the ID physicians, and there was a very good relationship developed between the mentors and the mentees, that is the fellows. So with also the dedicated web portal, as I mentioned, and a learning repository and the professional networking via the WhatsApp group. So this was basically the training model developed. Next one. Next slide, please. So after the call was sent for the fellowship, we received more than 120 applications, mainly from the Doctor of Pharmacy students who had recently graduated. And then we had rounds of discussion with them. We selected the fellows who had keen interest in ID, who had passion for ID, who had done some basic courses in AMS, AMR from WHO, etc. And based on the rounds of discussion and interviews, we finally selected 10 fellows, 10 PharmD students for this fellowship program. Next one. And this is the screenshot of the web portal, which we developed specifically for this project. And we named it as IPID Pharmacist Fellowship Portal with the support of Avenida. Next one, please. Next slide, please. Yeah. So the orientation meetings happen, lots of Zoom calls, and all the fellows and our team members, we were guiding the students for use of portal as well as for the fellowship routine. Next one. You can go on. Go to the next slide, please. Yeah. So these are some of the photos of our fellows working in the hospitals with the patients, with the ID physicians, etc. Next slide, please. Next slide. Yes. So these are some of the online sessions conducted by the ID pharmacists like Dr. Grace or Dr. Saidulu. In fact, one of the co-panelists, Dr. Gautam, also conducted a session for the fellows. And it was really very fruitful to have such online interactive sessions. Next slide. Next slide, please. We had, as I said, monthly work done reports. So we had extensive documentation during this fellowship. And the fellows were writing down their routine program, their routine, what they did before lunch, after lunch. So it was very exhaustive work for them, but they did it very well. And we were closely monitoring it because we wanted to know how the fellowship is going on and what exactly are they doing, whether is it happening as per our plan. Next slide, please. So some of the sites, hospital sites we visited. So I visited one of the site in Hyderabad, the AIG hospital, and met the fellows as well as the mentors. Next one. And the assessments were done. We did the assessments based on our study curriculum. So the curriculum was divided into 4 parts, and each time they were given part of the curriculum to study for the assessment. And then the assessments were taken online. Next one. And also the scoring was done very seriously. And they, next slide, please. Some of the fellows presented their work at the conferences. I myself participated in some of the conferences talking about this project, talking about the role of pharmacists, talking about the ID pharmacist. And towards the end of the, next one. Towards the end of the fellowship, after the 4 assessments were completed, final interviews were taken by our ID expert committee members. And then finally, we evaluated them based on all this, as well as their attendance. And then they were awarded the certificate for their fellowship, which they can use as a very proud achievement of the fellows during their career. Next one. Now, after this fellowship, next slide, please. So also all the fellows proudly participated in the World Pharmacist Day, and then they promoted the theme, Pharmacists Meeting Global Health Day. That was year 2024. Next slide, please. Next slide, please. Yes. So now the fellows have been writing articles on their fellowship, and they are writing in our IPA-CPD time. So this is also very clear and nice evidence of what fellows have done, what have they achieved, what are their perspectives. Next one. Next slide. Next slide, please. Yes. So just taking an overview of this 1 year project, of course, the 6 months for the project development and 1 year of the fellowship. And now we are doing the final evaluations. So ID fellowship program for the pharmacist was the first of its kind of fellowship with a decent stipend with the support of Pfizer's education grant and implemented, of course, by IPA at the reputed hospital. Fellowship was completed smoothly by all the 10 fellows. ID physicians and hospitals highly admired this initiative and they appealed to continue the fellowship and scale it up, which was very encouraging because when we started the project, in fact, me personally also, I was not very sure how will this be taken up and how the fellows and the mentors, the ID physicians, the microbiologists, how will they get along with each other and how will this work, whether this will serve the purpose. And then but it did. And the ID physicians really appreciated and admired the work of the fellows. And in fact, there have been so many requests for the collaboration from some of the medical colleges in India that we can do this program collaboratively and take it up, scale it up. Now, having said all this, there are some learnings from the project. The frequency of interactive virtual sessions that we organize, I think that was less. We need to do much more. Also, I think regular visits by some of our project team members or colleagues to the hospital sites would be very helpful. So one-to-one discussion, one-to-one interaction with the fellows at the site would be helpful to gain more insights. And now we are in a phase of taking feedback, detailed feedback from the fellows and mentors so that we can do the final critical evaluation of our fellowship and then we can improve it in our next phase. Next. But overall, this project gave us a lot of confidence that the ID pharmacists will be appreciated. ID pharmacists are needed. They are doing the work that is expected and they can be part of the healthcare team, which can improve which can lead the AMS, antimicrobial stewardship, and this can help definitely the responsible use of antibiotics. And overall, we can try to mitigate this by this collaboration, by this teamwork, the AMR. Thank you so much. And I'm sorry for my unstable connection in between. I hope you could hear me. Thank you so much, Dalal, again.
Thank you so much, Manjiri, and I should say congratulations on this first of a kind fellowship in your country. And we should take a moment to celebrate your success and the passion in which you have described this initiative. So best of luck in conquering the next steps. We move now to
Thank you so much.
Last but not least speaker. Thank you, Manjiri. We move to our last but not least speaker, Dr. Yvonne Ikisu, who is the rector of the Ghana College of Pharmacists in Ghana. And Dr. Yvonne is going to present another experience also from her country, where she will discuss specialization in pharmacy practice, the experience from the Ghana College of Pharmacists. Dr. Yvonne, we are so happy to have you on board. Please go ahead. The floor is yours.
Thank you very much. And I'm grateful to the organizers of this program for inviting me to share what we are doing at the Ghana College of Pharmacists. So the Ghana College of Pharmacists was established in 2011, and it is set up by an act of parliament. So we are an agency of the government of Ghana through the Ministry of Health. And our vision is to become a college of choice for the training of world-class practitioners in specialized pharmacy services for quality healthcare delivery. We hope to do that by developing and imparting the needed competencies through education and training for the delivery of improved pharmaceutical practice and health policy formulation. And all of these go to meet the mandate the mandate of the college, which is set out in the enacting the act that established the college. That is to promote specialist training in pharmacy and related disciplines, promote continuous professional development in pharmacy and related disciplines, promote research in pharmaceutical practice and related disciplines, and contribute to the formulation of policies and sound health, medicines, and public health in general. So at the college, there are certain things that we take very, very highly. We regard highly, and those are our core values. We believe in professionalism, excellence, teamwork, and collaboration. And so I was very happy when Gautam was talking about the synergies between the physicians and the pharmacists. We believe in integrity, transparency, and these are all things that we work with throughout. And one of the things that we do not want to go down at all on is innovation. But our focus is to build up the competencies of practitioners as specialists, pharmacists, and specialists in other related disciplines. Next slide, please. At the college, we have 3 divisions, and each division has 2 faculties. And these divisions cover generally the practice of pharmacy in Ghana and the West African sub-region. And so we have the Division of Pharmaceutical Care, which has clinical pharmacy and community and family pharmacy. We have the Division of Pharmaceutical Production and Quality Assurance, which has faculties of drug and herbal medicine discovery, development, and production, and faculty of quality assurance. And we also have the Division of Social and Public Health Pharmacy, where the faculties are social and administrative pharmacy and public health pharmacy. Next slide, please. In executing our mandate, we try to ensure that everything that we do fit within the mandate that is set out in the Act. And so we talk about specialist training, and this we do through our primaries, our membership, and fellowship. We have highlighted monitoring because we think it is crucial to ensuring that the candidates who come out have the requisite competencies to provide specialized pharmacy services as well as specialized services in related disciplines. Usually at the primaries level, all candidates will be pharmacists. They are practicing pharmacists. They would have practiced pharmacy for at least 2 years. Until recently, it was 3 years, but now most of our applicants are PharmD pharmacists, and they must have practiced pharmacy for at least 2 years, and they should have determined their area of specialization, or at least an area that they are interested in before they come. We take them through a year of primaries, lectures, and some exposure that we think, some areas, communication, leadership, that we think are very important for pharmacists who are the middle level and who are rising. Then they go into residency for the membership program, which is a 2-year residency, depending on their area of specialization. For clinical pharmacists, which is the area of focus for us, when we are talking about ID pharmacists, they will be in teaching hospitals primarily, and then hospitals for specialized care. Then at the fellowship level, they do some sub-specialization in their area that they would have chosen. I mentioned monitoring, and we do that in various ways. They have to have logbooks. They give us reports. We also visit them regularly at the sites. We ensure that the sites have, during our visits, these are monitoring visits, and so we have to assess the whole site that we are working with, their equipment, the facilitators, the preceptors, and the researchers who are supporting their research. We currently have introduced a joint qualification program where candidates who register through the Ghana College of Pharmacists can go on not only to come up with a membership, but also an MPhil. And this the newest one, or the first one, is with the Kwame Nkrumah University of Science and Technology. Candidates who are also seeking fellowship can come out with a joint qualification of fellowship and PhD. Research is very important to us because we think that as practitioners, there is the need not only to work, but also to show some of the things that are coming out from the work. And so it is required that both at the membership and fellowship level, every candidate will go through some research. They are also encouraged to participate in scientific conferences and annual general meetings. And indeed, at the Ghana College of Pharmacists, every year we have an annual general meeting and scientific conference, and we encourage our candidates to share what they have done over there. We have also recently established an institutional review board. Previously, the candidates were going through their ethical research, ethical authorization through their institutions. And sometimes it was a bit tricky. And so we have recently instituted our IRB to facilitate the work. We understand that not every pharmacist or every person who is in a related discipline will be able to take out 2 years to come and do the specialization. And yet every pharmacist and every practitioner may be looking for opportunities for specialization in some areas. And that is why we have developed our short courses. So we have the medication therapy management. We have trained pharmacists across the sub-region. So we have pharmacists we have trained from Liberia and Sierra Leone, who we trained in the handling of chemotherapy medications. We train pharmacists as vaccinators. We also train pharmacists to provide clinical breast screening and also to work as asthma care managers. We have recently designed a program to support the pharmaceutical industry, and that's also a short course where we are training qualified persons for production. And so for specific production lines, they will be signing off on products. And also for the multinationals and other companies that do sales and marketing, we have a program for them on the Code of Marketing and Sales, which will be rolling out for them. We have recently introduced a program in palliative care, which we are getting for all our practitioners. Recently, we have been exposed to how very critical palliative care is for the practice of pharmacy. With respect to policy, we have a journal, our GCP journal and our GCP publishing platform, which allows us to receive research work, abstracts, and all that, and also publish in the journal. And we actively participate in engagements with our ministry, as well as some of its agencies. We normally participate in national and international conferences, including FIP. And at the last FIP Congress, we had 2 posters from the college specifically, even though we had quite a number of posters from candidates, from the work of candidates who have gone through. So our fellows and our members as individuals submitted posters, various posters at the FIP. The GCP journal is also registered with FIP, and we have a very vibrant website. Next slide, please. So when we go through for our training, we have update lectures. Our candidates go for clinical practice. They go through clinical rotations. They undertake research. As I mentioned, they also have to fill their logbooks and report annually to us, not only on what is in the logbook. Their logbooks have to be signed off by their preceptors. These preceptors are usually pharmacists who are specialists, but in areas where we do not have pharmacists, we also rely on other professionals like medics, like nurses, like other professionals who are like medical laboratory professionals. Then we have publications. The candidates are required at the membership level to submit 1 article for publication, and at the fellowship level 2 for publication in order to graduate. Next slide, please. For our residency program, and now I'm honing in on our ID specialization. At the Ghana College of Pharmacists, For clinical pharmacists, they are required in the first year to go through a general rotation that every clinical pharmacist will go through the year one, as you can see on the left of your screen. So introduction to clinical pharmacy practice, they'll do some rotations in internal medicine, infectious diseases, child health, emergency and accident care, general surgery, and then they'll also do some rotations, which these rotations are, we call them electives. So if this is not what you are specializing in, then we require you to take an additional 4 weeks in one of these. You just take one of them and take a rotation in that. But when we are talking about our ID pharmacists, we have this, what I've shown you is a typical of one candidate. So depending on the institution, some of the arrangements may be different, but they'll go through microbiology. So they'll go to the lab for a rotation in the laboratory. Then they will do institutional ID. Then they will do community ID. We think it's important for them to understand that both institutional, even though they will be working in the hospital setting, to also look at what is happening in the community. So at the institutional level, they have to do something in AMS and IPC specifically. So this is separate from all the other things that they will be doing in their other units: urology, obstetrics, internal medicine, nephrology, general surgery. So they are required to go through rotations in all of these. Their preceptors will sign them off as having gone through the required rotations before they can come in and do their final assessment for examination. And I must say that their assessment will include, we will look at their dissertation, which comes up from the research reports that they have done. We will assess their logbooks, and then they will also do an exam, a written exam, as well as an oral or bedside exam. Please, next slide. So this is just a focus. This is looking at the various rotations that I have mentioned earlier. So I'll just leave the slide on for maybe a minute for all of us to just take a look at it. I'm not going to run through it, but just to bring out the fact that the ID specialization that we are requiring, or that candidates at the Ghana College of Pharmacists are going through, are really equipping them to provide the necessary services, the necessary support in infectious disease, in communicable diseases, in the hospital setting, wherever it is that they find themselves. Remember that this is at the membership level. Now, when they get to the fellowship level, they will be at liberty to take one or two of these areas specifically, and then go into those in depth and become experts in that area or two. Next slide, please. So just to summarize, our training is comprehensive and it is competency-based. So yes, there is the academic bit of it, as in we do update lectures, but we require our candidates to show that they can actually do what it is that we're expecting, the service that we're expecting them to provide afterwards. They have to show that competence before they are deemed as having passed. And in this way, we are contributing to the needed human resource for fighting AMS, AMR, communicable diseases, in addition to all the other specializations that we provide. We currently have fellows. We have 3 fellows by coursework who have gone through all the training and have also subspecialized. We have 18 members who are now, we will call them specialist pharmacists in infectious diseases. And we have 15 candidates who are currently going through the training. Thank you.
Well, thank you very much, Yvonne, for your intervention. It was really valuable insight as well. And now it's time, I think we still have 10 minutes left. It's time for the question and answer period. So I don't know, Dalal, if you want to start reading out some of the questions, but I'm afraid some of them were already answered now by our panelists. So let's focus on those that are not answered yet. I'm
Yes.
afraid most of them are some comments related to the career options, no? There is an initial reflection, which is really interesting from my point of view. I'm going to read out and then we can proceed with the following. Marianne Chapara says that it's really interesting and holistic approach. Reference was made to the role that clinical pharmacists have in rural areas in developing countries. Given that community pharmacists are accessible to the general public and clinically trained, they are in a unique position to address AMR given that they undergo specific training in AMS. Probably most of you agree with this statement. And
Yeah.
the other question are related to job opportunities. For instance, they say, is there a research idea that is helpful for the improvement in the PharmD? And they are asking about the PharmD career opportunities. I don't know, it's an open and general question. If some of you want to answer, sorry.
Carlos, hello. Hello.
Hello. Yeah.
Hi, I hope you can hear me. So one of the things, one of the questions which was asked by a colleague from Zimbabwe, and I think I did not mention about that in my presentation. So she has been asking about what are the job opportunities for the fellows who have completed their fellowship in the infectious diseases. So I wanted to mention that most of the ID pharmacists, the fellows, have got jobs in the same hospital where they did their fellowship. That itself indicates that how much is the need for the ID pharmacist and how much the hospital administration as well as the ID physicians trusted the fellows and their competencies developed during the fellowship. So I think there is very bright future for the fellows, not only in the hospitals, but elsewhere in the research. And yeah, so it's a way to go. And I think there is need to develop such type of specializations. And I was very impressed with the presentation from Ghana also. Very nicely designed residency program. Thank you.
Thank you, Manjiri. I think there are also, Carlos, some questions maybe Yvonne can attend upon. Questions related to the fellowship at your College of Pharmacy. So there are questions whether you accept fellows from outside Ghana, and also when is the next fellowship going to start. So maybe Yvonne, you would like to attend on that regarding the fellowship in your country?
Yes, thank you very much. So yes, we do admit candidates from outside Ghana. Indeed, for some of our short courses, we have already trained candidates from across the sub-region, and we are in discussions with candidates from other parts of Africa to participate in some of our short courses. But our specialization programs are also open. Even though it is from Ghana, all the authorities are aware that we are open. Our parliament is accepting of candidates from across, everywhere in the world. So anybody can apply. You go to our website and you just Google Ghana College of Pharmacists and you will find our website. And you just go to our website and look through the programs that you may find interesting and apply. I must say that we have just recently started our latest, we have completed our latest admission for primaries and fellowship. And so sometime at the end of March, early April, we will open admissions again for the next cohort. And so if anybody is interested, just start preparing for that, remembering that it is 2 years, or you can come and do some of our short courses, which will be of a shorter duration. Thank you.
Thank you
Thank
so
you, Yvonne. We
much.
received, sorry, Dalal, we received another question. I believe it's addressed to you, Noor. It says, for the infectious disease consultant, when you say shorter durations, what does that mean in practical terms? Same with limit broad spectrum use. They thanks in advance.
Sure, shorter, always better, assuming that there's evidence behind it. And there's a lot more research coming out on what short actually means. Is it 7 days for pneumonia, community acquired? Is it 5 days? Is it perhaps 3 days in some situations? And the studies themselves could be a little bit confusing because perhaps in some situations the diagnosis of pneumonia perhaps was overcalled in community acquired pneumonia. And that's why we need to be very careful of how we take this information and apply it to patients, and really think about the patient themselves. But generally, when you're trying to incorporate durations into your guidelines, it would be really good to consider. I work currently with the WHO that could consider things such as the AWARE book and other national guidelines that are really focused on duration and in the first place stopping antibiotics. The second part was on, can you remind me, Carlos? I'm sorry.
Limit broad spectrum use.
Yeah, the whole idea is risk benefit. So what is the benefit of adding this antibiotic that has one additional organism that it covers? Specifically, if you wanted to consider an example such as anaerobes. Adding anaerobic coverage so often is taken for granted as not a big deal, but actually anaerobes form a big portion of our normal flora in our gut, and it has significant repercussions on the long term on our health, on our metabolism, on our ability to manage new infections that we get colonized with. So not to take too long, the idea is it's not about limiting broad spectrum use, it's about making sure that you use broad spectrum for the best patients. So for example, someone asked about ceftazidime avibactam. I'm sure they can refer to the package insert, but the whole idea behind ceftazidime avibactam is it's so broad that if you use it in the wrong patient, then you are doing more harm than good. So it's about finding that balance. And in order to do that, you need to know a little bit about the science behind it, so microbiology and spectrum of activity, and you also need to know the patient and what the patient has. So I hope this addresses this question a little bit. It takes a bit more time. Thank you.
Thank you for your points.
Also, I think, Carlos, if I can just jump in there, you're selecting for resistance when you use these broad spectrum antibiotics when you don't need to. And so, probably you're going to have a pathogen that's resistant to ceftazidime avibactam the next time around. So I think that's kind of where we worry about using or using broad spectrum antibiotics when they don't have to be used.
Okay. So maybe Carlos, we would like to end this on a good note, maybe asking the panelists in perhaps one word to describe, 1 or 2 words to describe where they see the future of pharmacy specialization in antimicrobial resistance. So what would your word be, Manjiri?
Hello. Hi, Dana. Yes, so that's the way to go. The ID pharmacist is the future, and we need to work interprofessionally. Working together is the way ahead, or if we want to mitigate AMR.
Thank you. What would your take, Yvonne, be on that?
I would say the future is bright, and there's no stopping us. Once we can hone our skills and contribute better, there is no stopping us. Thank you.
Thank you so much. Noor?
Untapped opportunity. So finding ways to bring people in to help stewardship.
Thank you so much. And the last word comes from Gautam.
Yeah, I think, the ID pharmacists would really be the flag bearers of our fight against or kind of championing antimicrobial stewardship. I think just listening to all of y'all, there's going to be AI, which is, I think, the elephant in the room, and I think we'll really have to make we'll have to cater our training processes to take that into account, because if you're really looking at, say, what drug to a bug and then what side effects, I mean, ChatGPT can do it, but I think based on what I've heard all of you talk, I think we're heading in the right direction, because that involves talking to people and training and things like that, which I think you guys have really set the path very clear. And so I think, really the flag bearers of this.
Thank you so much, Gautam, and thanks for all our panelists. Thank you also, Carlos, for co-moderating this with me. We need finally to end up. It was very nice listening to your experience, but for the interest of time, we need to conclude this webinar. So it is always interesting to learn from everyone, their experience in antimicrobial stewardship. Today, the topic was on specialization, and we have seen how diverse low and middle income countries can be in what they design for a specialization in pharmacy. And this is maybe an invitation for any of the attendees. We have 400 plus and still counting who would like to know more about those programs and maybe design their own, to get back to those people who have already shared their experience and learn more from them. Lastly, we would like to share with you the next slide, please. So if you would like to get back to this event or to any of the FIP events online, you could listen to the recordings by visiting this website, events.fip.org. So if you're interested, and this is also the invite to the 84th FIP World Congress of Pharmacy and Pharmaceutical Sciences, which will be held in 2026 in Montreal, Canada. The theme of the Congress of the next year is One Health, One Pharmacy, Bridging Science, Practice, and Education. As usual, it is a very interesting theme, and of course, building on the success of the previous conferences, the last one in Copenhagen, and moving forward, we invite you to register and look into the Congress themes and sub-themes. So these are the sub-themes: integrated health, some of which have been described today when our panelists described interprofessional education, innovation with purpose, or innovating with purpose. Of course, Yvonne and Manjiri have described their innovation from their countries. Collaboration for equity, as mentioned by all our panelists. So collaboration between healthcare providers, and also Noor and Gautam has mentioned patients and people as well. So you might like to look into the sub-themes and the themes and know more interesting details about the upcoming Congress. I think by this we are done. ISO. Okay, so thank you so much for attending. It was nice being with you today, and we look forward to the next webinars from FIP. Have a good day and a good night, everyone.
Thank you.